So welcome to this clinical contact session today, and this is week 8, as every one of you is aware. And last time, unfortunately, we had to cancel the session of CNS, OIs, and TB. Of course, that was really important session. But when we discuss about opportunistic infection these days, I think it is good to mention here that those who are working in HIV since long time, they are aware that when we started practice in HIV, we used to come across so many opportunistic infections, and we used to treat them also in the ERT center, in the wards, and also in the other places. But these days, whenever we talk about OIs, also in the program, we talk more of TB uh, in terms of OIs. But the other opportunistic infections, these days, we are less frequently seeing them. And those who are working only in the RT centers, I doubt hardly you will see serious OIs like cryptomeningitis or toxoplasmosis. And I don't know how many of you might have treated those opportunistic infections if you are working only in the RT centers. But even now, as part of one of the presentations of the UW, you might have seen that uh, there was a discussion on late presentations of people living with HIV in care, which means that even now we are getting some patients at least who are, or a considerable number of patients who are in the late stage of their HIV infection. That means their CD4 count is low. But as I said, most of the times what happens is when they get all these infections or when they get symptoms of all these infections, they get to take services from the institutions rather than coming to the ART centers. That is why sometimes we don't see those many OIs. And on the other hand, with this treat all strategy and with expansion of ART program as such, what has happened is people are being put on ART soon, and which is giving less time for the infections to again manifest. And that is the other reasons why globally also we are seeing decline in opportunistic infections. And in India also, if you look at the overall incidence of OIs, that has considerably reduced. I would not say it has reduced like overall, but yes, as compared to what was happening 10 years back, now it is lesser than before. But as I mentioned, TB is one OI which we are coming across very commonly, day in, day out. And CNS OIs, they are really still important because if we do not suspect CNS OIs early and if we do not treat them on time, patients may die because of them. But the other OIs, like non-CNS and non-TB OIs, are those which are, some of them are not uh, specific to HIV, but some of them are again AIDS related opportunistic infections. So for this week's theme or module of non-CNS OIs and non-TB OIs, so we'll be talking about some diarrheal diseases and also PCP, pneumonias, and also iris was one concept which was explained in this week. So we can just run through those slides also. And regarding early manifestation of or late manifestation of HIV infection itself. So those are the things which we'll be touching base upon. But as we mention it every time, it is really important to go through those two sessions to solve quizzes and do homework assignments. So this will be, I'll be just talking about the Indian perspective and sharing the NACO experience related to non-CNS and non-TB opportunistic infections. So these are the slides from the UW faculty session that when HIV came in the beginning in 1981. So it came with the OI only. So initially there was a group of gay people who got admitted in with PCP and also Kaposi sarcoma, which was not seen at that point of time in immunocompetent population. So that there was a surge on in that as well. 26 gay men were admitted in New York with Kaposi sarcoma. So that was an alarming sign of having some kind of immune suppression in these patients, and because of all these infection and sarcomas, which is otherwise not happening in immunocompetent persons. So in 1983, so the name was given as HIV, and then you know how that uh, uh, went along. In 86, India saw first patients in southern India and also in northeast, and then after that, it number went on increasing. So when we talk about opportunistic infection, its correlation with the CD4 count is really important to understand, because sometimes what happens is most of these OIs, if you see, uh, uh, they can be clinical diagnosis of some of the infections. But the other infections, if you see, for example, oral candidiasis or oropharyngeal candidiasis, we can diagnose clinically also. You need not do lab confirmation most of the times. But some of the OIs, they need lab confirmations. So sometimes it is really difficult, and many of us in our facilities, we don't have all these tests available or investigations available to confirm OIs. So for treatment purposes, it is really important to know what is the level of CD4 count. Based on that, we can predict the opportunistic infection. For example, if I'm predicting CMV retinitis in a patient, and if I look at the CD4 and if CD4 is suppose 600, then I would say that CME retinitis is unlikely. Let's rule out the other causes. Similarly, if I'm talking about TB, for example, if it is pulmonary TB and in the lungs, if you are looking at cavity formations and all that, and if the CD4 is again more than 500 or good immune system, then it is more likely to have that kind of TB. And if CD4 is low, I can assume the disseminated type of TB. So at the level with the level of CD4, we can predict opportunistic infections also. That is why it is good to have this understand or remember this correlation between OI and the level of CD4 count. So most of the viral diseases and all that, if you see, if the CD4 is below 200, you will see most of those opportunistic infection. And as we know that in typical course of HIV, it usually takes almost 8 to 10 years to for a patient to come into that stage of less than 200 CD4 count. But obviously, there are different types of patients like rapid progressors and all, where you will see decline of CD4 very faster than usual. So these are some of the examples of common OIs which are seen in India. Not necessarily, this is not an exhaustive list. These are some common OIs, especially in HIV. They can be bacterial, viral, fungal, or parasitic. So respiratory can be any streptococcus infection or influenza or viral pneumonias, and these days again COVID. So these are the again otherwise also common OIs, and not forgetting TB, which is the leading opportunistic infection in PLHIVs. So again, the viral CMV, herpes, viral varicella zoster, and zoster, and then fungal. Again, if you look at PCP or PJP, pneumocystis jirovecii pneumonia, formerly called as pneumocystis carinii pneumonia, this has been classified as organism uh, of belonging to fungal OIs, or it's atypical fungus, which is being defined as based on its characteristics. So that is something which is which was more common in past, and nowadays you will see lesser and lesser type. Some of the OIs are preventable. For example, if you are giving primary prophylaxis of PCP of cotrimoxazole, so it can prevent PCP. Also, it can prevent toxo, which is one of the parasitic infections. It may prevent some of the diarrheas also, and also it can be preventive for pneumonias. That is why CPT prophylaxis or cotrimoxazole prophylaxis, after a specific cutoff, scientifically speaking, less than 200 is appropriate. But if you go by guideline, it still says it is less than 350 CD4 count. The patients are eligible for CPT prophylaxis, and all those who are having TB co-infection also will be eligible. So basically, these are the three factors based on which it is the association of opportunistic infection can be considered. One is exposure to the organism. So that is why some of the geographies, you will see more than usual prophylactic medications which are being prescribed. For example, in NACP, in Indian program, you will see primary prophylaxis only with the CPT. You won't see uh, primary prophylaxis for MAC, like azithromycin, or primary prophylaxis for other diseases. This is because of, again, it is based on in the geography, in a particular geography, what kind of infections you are seeing. So, and if the primary prophylaxis will be useful or not, based on that, it is decided. So even if it is there in the other Western guidelines, and then in the Indian guidelines, you will see primary prophylaxis of only cotrimoxazole. So it is based on exposure to the organism, then virulence and property of the organism, and also the competency of the immune system of the host. So these are the three basic factors which decide the happening of or the occurrence of OIs or not. When we look at immune system, we talk about CD4, and also based on the system involved, again, we can predict some OIs. And I was mentioning about geographies. Some of the OIs like tularemia, which was mentioned in the session, UW session, but formerly known as Penicillium marnefi infection. So that is still common in northeastern part of India, especially in Manipur, and also Southeast Asia, basically. So Penicillium marnefi, which is again maybe still seen in people from Manipur. Then again, it depends on if the patient is on ART or not on ART. So these are some common presenting symptoms. Again, this is very old data, but patient may present with any particular symptom based on the system which is involved, but these are general symptoms. Then again, if you look at the overall causes of mortality and morbidity in HIV positives with ART, so obviously this is now changing the scenarios that earlier we used to see most of the hospitalization because of opportunistic infections, but with time you will be seeing, again, because this data is suggestive of bacterial and again other diseases, but with time you will be also seeing the patients on ART with complications related to ART, causing diseases which are lifestyle related, and because of that we may see a hospitalization in patients. This is again a meta-analysis from 2005 to 15 showing um, morbidity and mortality related to HIV in patients who are on ART. This is again global cause of death. So 54% of the patients, if you see, they again non-AIDS related deaths also, if you see, and related to the opportunistic infections. Like I was mentioning about the geography, there are some infections which are common to particular geography, which is related to the country specific or regional geographies. TB is still most common opportunistic infection in India, but also in the some of the African countries, but that is not the case in the Western population. But whereas if you see all these PCP and all is still more common in Western world than in Eastern or Southeast Asia. This is list of malignancies which or HIV-associated opportunistic infections and malignancies, which can be there in, especially if the CD4 count is very low, and they are called as HIV-associated infections or HIV-associated malignancies. And this list you might have also seen when we had discussed in the first session regarding WHO clinical staging of HIV. And when we do clinical staging, that is based on the OIs which we diagnose based on the lab reports and also based on clinical presentations. So that is, those are the two criteria based on which we put patients in a particular category of WHO clinical stage. So it is an exhaustive list of HIV-associated OIs and malignancies. So it can be correlated with the clinical staging as such. So when we talk about prophylaxis, so few things need to be considered. That the infection for which we are giving prophylaxis, that should be common and it should be predictable. That this is what I was mentioning in the beginning itself. and it should be clinically significant. So unless until it is clinically significant or predictable, there is no point in giving drugs for those particular infections. That is why in India we end up treating patients with primary prophylaxis of TB, that is in terms of IPT we give, which is actually a treatment of latent infection. But more appropriate example will be CPT, cotrimoxazole prophylaxis. And it should be non-toxic, and also it should be affordable. So, as I was mentioning in the beginning itself, HART, or highly active antiretroviral therapy, or ART, has this effect on OIs, that it has caused decline in incidence of OIs. It has reduced the need of opportunistic infections, and also patients are surviving longer. And but again, it is coming with immune reconstitution effects. So with the scale up of ART program, the incidence of OIs has come down. So that is what is being predicted. So there are some OIs which do not have treatment, and they are treated with ART alone. The classic example is PML, progressive multifocal leukoencephalopathy. And again, I'm sure that people who are sitting in the ART centers only, they may not have seen these patients. But those who have worked in wards before, especially like 5, 6, or 10 years back, they might have seen so many patients of PML. And this is one of the infection of JC virus, which affects brain, and where you see the leukoencephalopathy, which is multifocal, and it progressively increases. That is why it is called as PML. And in which, again, this can be confirmed with lab diagnosis of JC virus, but also the imaging techniques by doing CT or MRI, you see shadows, and by which you come across, you may do the diagnosis, but usually it is diagnosis of exclusion. There is no specific treatment for this, but once you start, if you start ART early in PML, you can arrest the progression of PML. So that is how it works. And now cryptosporidiosis, and also it is similar. Sometimes we use other drugs like nitazoxanide and things like that, but usually it doesn't work unless until you start patients on ART, diarrhea doesn't go off. Similarly, microspora and Kaposi's sarcoma is another example. MAC is another example. So there are no specific treatments for all these diseases, but once you start these patients on ART, most of the times we see arrest of these infection or decline in the presentation also. So some slides from the second session regarding late presentations in the ART center. It is not the problem of only resource limited setting. It is problem of, again, resource rich setting also, where the still patients are being presented late, and reasons are not only because of poverty, stigma, or sex and other factors, but again it is self stigma, or multiple factors may get involved, and that false feeling of well-being. So because when they are diagnosed, they do not have any clinical signs and symptoms. That is why they do not access clinical care. So that also leads them to present late in the presentation, in the HIV infection. So when CD4 declines, and when they progress in their HIV disease, when they get OIs, then the patients usually present to the ART center. And and as a consequence of that, there will be increased mortality or morbidity because of HIV. And also, as an effect of that, patients do transmit HIV to their partners and also to the children. Their own life expectancy and partners' life expectancies goes down, and ultimately it will reduce the or it will actually increase the healthcare infrastructure, the expenditures. Now, this is an algorithm which is again just an example to show how this can be made, but there can be multiple algorithm which can be used for patients presenting with prolonged fever, and sometimes we call it as pyrexia of unknown origin, PUO. But again, if it doesn't fall into the specific definition of 3 weeks fever and hospitalization and investigations not revealing cause of fever and all that. So we can just call it as a prolonged fever of a week or more than a week's time. Um, if there are pulmonary signs and symptoms, we go with X-ray, and there is a separate protocol. If there is CNS signs and symptoms, again there is another protocol of ruling out by following if the patient has headache or no headache or global symptoms, or patient is showing some focal deficit and all that. Based on that, algorithm may vary. But if there are no associated signs and symptoms, and if there are any lymph node on general examination or regional examination, then you end up doing biopsy of those lymph nodes to find out definite cause. And if a biopsy is suppose inconclusive, or if you are not able to do lymph node biopsy, then you may go for USG abdomen. And if there are no associated symptoms on physical examination and no lymph node also is palpable, then you can directly do USG abdomen. And on USG, if you see a typical multiple lymph node enlargement, then you may go for CT guided biopsy, but most of the scenarios it won't be possible. So we end up treating those patients as abdominal TB. But ideally, those patients should be reviewed for diagnosis after some time for clinical improvement like weight gain and all that. And if not, then other diagnoses need to be considered. And if we don't get anything on the ultrasound abdomen, then we may go for bone marrow biopsy also to diagnose the cause of fever in such patients. Usually, we do not go till liver biopsy because of the simple fact that in many of the organizations that is not an option available to us, and we end up treating patients with empirical treatments of high dose or advanced antibiotics or anti-TB treatments. So empiric treatment for fevers in people who are from those endemic areas of malarias and all that, those need to be treated for malarias, and then we need to treat them with high broad spectrum antibiotics or third generation cephalosporins. And again, for patients who are eligible for ART or fit for ART initiation, in them ART initiation is done, and for to reduce multiple occurrence of OIs, nutritional advice and regarding cleanliness and washing vegetables and hand washing, those routine measures are advised. And wherever it is applicable, cotrimoxazole prophylaxis started, and if it is feasible, then vaccination with Hep B and pneumococcal vaccines need to be given. Obviously, NACO do not provide these vaccines, but if it is available and feasible, that can obviously given in patients if the CD4 is more than 250. Leishmaniasis in some of the geographies in India, for example, Bihar, Eastern UP, and West Bengal, Jharkhand. This is the region where you will see visceral leishmaniasis more commonly, and there you might want to do special investigations to diagnose visceral leishmaniasis in such patients also. And if it is diagnosed, then the patients are being treated with amphotericin B. And as I was mentioning regarding Penicillium malnefi, which is a fungal infection, so if you are in Northeast, or if the patient is traveling from Northeast to other parts of the country, then it is especially important to ask the history of exposure to bamboo rats or uh, merely their geography itself or travel history to Manipur. So it's and or all other parts of Northeast also with this clinical features of fever, generalized lymphadenopathy, hepatosplenomegaly, anemia, and skin lesions. You can suspect Penicillium malnefi. And if you see them, this is how it looks like, and it is treated with amphotericin B or itraconazole is given as a secondary prophylaxis in those patients. So in OIs, it is relevant with ART because that temporal relationship with ART initiation is really important. If you are getting any OI, sometimes it can be unmasking of OIs after initiation of ART because of earlier compromised immune system, which is reinvigorated after initiation of ART. And then that reinvigorated immune system responds to the presence of unmasked or previous infection. And as a result of that, you will get clinical manifestation of that hidden infection after initiation of ART. That is called as immune reconstitution syndrome or paradoxical reaction or unmasking of previous OIs or post-ART OIs also. Sometimes OI may get manifested as failure to the treatment. So if the patient is on ART doing well, and if there are adherence issues or whatever, and if ART is not effective, then patients may get again OI, and that is because of again treatment failure presenting with this OIs. So there can be some role of steroids, especially if it is paradoxical reaction. But if it is undiagnosed OI or the other type of iris, then you will have to, then there will not be any role of OI. The steroids as such, you will have to treat the patients with OI specific treatment. So this is, you might remember seeing this slide before also. This is oral candidiasis or oral thrush. So if you look at this, this is very typical curd-like appearance in mouth. It is treated with fluconazole, 100 milligram once a day for 7 days. Usually it is enough. If it is esophageal candidiasis, you can give 200 milligram OD fluconazole for 2 to 3 weeks sometimes. Uh, but odynophagia can happen when patient complains of pain in deglutition. It can be if the patient is showing oral candidiasis, usually it is because of esophageal candida. But sometimes if it is not reducing with fluconazole, then it is advisable to do endoscopy. And if you see any lesion, biopsy can be done. Sometimes these are viral ulcers, or you may have even TB ulcers also in esophagus. And sometimes it is merely because of HIV. And once you start ART, those ulcers also go down. So, oroesophageal candidiasis, again, one of the commonest OI. And if you see this for oral candidiasis, you put these patients in WHO clinical stage 3. And if it is oroesophageal, it is WHO clinical stage 4. But if you want to send in labs, this is how it looks like. Tongue scraping, candida, and these are the colonies of candida albicans. These are the other causes of esophagitis like CMV, herpes. So based on the diagnosis, you need to treat them. And as far as algorithm goes, initially we don't advise endoscopy or any procedure as such. So you can treat with empirical course of fluconazole. If there is a response, you can just follow it up. If there is no response, you can refer the patient for endoscopy or then biopsy. If there is any conclusive diagnosis on biopsy, then you can treat with specific treatment. But if not, then you can give empirical steroid, or you may end up starting ART also in those patients. And sometimes with ART alone, it goes down. Diarrhea, there are a lot of organisms which are mentioned which can contribute to causing diarrhea, especially if the CD4 count is very low, like Cryptosporidium, Isospora, Microspora. But other common pathogens which cause diarrhea also need to be considered. So as our labs are also not well equipped, we are always not in a position to isolate all these organisms. So when a patient, when you get any patient complaining of diarrhea, usually we treat empirically in those patients with ciprofloxacin or ofloxacin, and in combination with metro or um, um, other drugs. But like metronidazole or ornidazole and all that. But if it is not getting subsided, then we may consider adding high dose cotrimoxazole, and also if it is not reducing, we may consider adding albendazole as one course treatment, which might get effective against microspora as well. So it depends on the clinical course and empiric course of treatment. But if you have well-equipped lab, it is highly suggestible that on day one, you should send the stool sample for isolation of organism. And some organisms like Cryptosporidium and sometimes even Microspora, which do not have any specific treatment, there the answer is only ART. And once you start ART, uh, uh, there is improvement in those infections. This is one of the studies to show the common organisms in HIV, especially if the CD4 count is very low. But principles of treatment are again to maintain hydration and to treat the electrolyte imbalance. And obviously, you would like to give symptomatic treatment to decrease frequency of diarrhea. This is an algorithm to guide us on, again, if the patient is having tenesmus or pain in abdomen or not, and based on that, how you decide to do whether empirical treatment or again to do other stool examination, when to do what. So it is very handy, and we will share the slides with you. So you can keep these printouts under your table, and you can use them as an when you want. So like as I was mentioning, you can give albendazole for microspora, you can give cotrimoxazole for isospora or cyclospora, and drugs like nitazoxanide can be supportive, but ultimately it is ART which is helpful. Um, Pulmonary manifestations, again, it may be related to the CD4 count. TB can be at any CD4 count, and likewise, even bacterial pneumonia can be at any CD4 count. But presentation will differ. Obviously, if immunity is low, you will have um, bad presentation of the patients with disseminated diseases, maybe septicemia and all that. But if you have, if patient CD4 count is good, then presentation may be confined to one particular organ system. So based on the clinical picture also, you may predict if it is because of bacterial pneumonias or TB or any other type of pneumonias. So whenever the patient is coming with pulmonary symptom, obviously for every patient, CBNAT is important in such scenarios for pulmonary symptoms, but for HIV positives, we can do X-ray for each and every patient. If X-ray is normal, then simultaneously we do CBNAT. If it is positive, we give ATT. If negative, we give prophylaxis and other things. But based on ABG or pulse ox findings, you also may want to, if the patient is presenting with, if saturation is reducing, then based on the clinical scenario, clinical findings, and also X-ray findings, you may decide treating patients with full dose of cotrimoxazole, maybe like 2 tablets 3 times a day based on patient's weight for 21 days. So that is a treatment of PCP. But if saturation is normal, then again you can just treat patients symptomatically if the X-ray is normal. But if X-ray is abnormal, again it is very much dependent on the um, immune status of patient, actually the CD4 count of patient. Uh, if it is bilateral initial infiltrates or fibrocavitary lesions, mediastinal findings, or miliary findings, or miliary mottling. So if it is bilateral interstitial shadows, then most probably, especially interstitial disease as well. If for consolidation, if you see any finding in lungs, um, you will go for CT genetic examination first, and based after ruling out TB and also simultaneously is negative, then you may consider other diagnosis. And if there is a fibrocavitary lesions or mediastinal lesions or miliary mottling, again after confirming ruling out TB with whatever possible means, sometimes you need to do CT chest or even HRCT or even MRI to come to a conclusion for treating the to decide whether to treat the patients for full course of anti-TB treatment or not. But most of the times you end up treating all the patients with anti-TB. Whenever you start any anti-TB treatment, please do consider revising your diagnosis if there is the response to therapy is not expected. This annotation to presentation, but if you look at this, very typical middle lower patient if presenting with dyspnea or dry cough, and also if you look at the saturation of oxygen, if that goes down. So this is enough to treat this patient for PCP treatment rather than to have a lab confirmation, which can be done in ideal scenarios with bronchoalveolar lavage after doing bronchoscopy and all that. But it is not necessary. You can just treat those patients on clinical grounds. So if you compare the presentation of PCP with pneumonia, PCP usually presents with dry cough and CD4 of less than 200, and there will be fever for some time, but it won't be like a high-grade fever in most of the cases. And if you auscultate the patient, it will be basal crepitation sometimes, but sometimes, most of the times, it will be normal. And if you look at the X-rays, it can be normal in mild PCP. In moderate PCP, you will be seeing perihalar shadows or interstitial markings. In severe PCP, sometimes it can be ground glass appearance also. While in pneumonias, it will be short duration of high-grade fever, sometimes associated with chest pain, and most of the times it will be with a productive sputum after coughing out. So cough with a productive sputum. Um, and dyspnea may also happen. Chest pain may also happen because of uh, pneumonias. So um, sometimes patients of pneumonia, they present with parapneumonic effusions also because of fluid collections, and that may give dullness or on percussion. And in PCP, these patients may present with a cyst, but very, very rarely they may present with pleural effusions. So that usually doesn't happen with PCP. But what is the significance of cyst in PCP is these patients will be prone for pneumothorax. So if your patient comes to you who is having very low CD4 count, suppose, and complains of sudden increase of breathlessness, or with some past history of fever also, suppose, you may think of PCP, but if it is increasing breathlessness or maybe tightness in chest and all that, please suspect pneumothorax in those patients, because those who have cyst are prone to rupture of cyst, leading to air inside the pleural cavity, causing breathlessness, and sometimes it is a tension pneumothorax which may kill the patients. So it is really important to differentiate between pneumocystis carotidae pneumonia and bacterial pneumonias, because treatment will be different, presentation will be different, and also the outcome of the patients with or without treatment will be different in these two situations. This was the example. This is the example of PCP in mild, moderate, and severe cases. I was just explaining that, but dry cough and oxygen saturation is really important. Ideal thing is to do blood gas analysis, but most of the scenarios it is not accessible to us. So easier thing is to do saturation of oxygen by applying pulse oximeter. In mild cases, if you suspect ECP and if saturation is normal, then you may ask patient to walk for some time and again recheck saturation. If drops down, then you may consider PCP also in those patients. This is again easy to treat disease, but if not treated, patients may die because of PCP. And treatment is high dose cotrimoxazole, uh, where you end up giving, if you calculate this 15 milligram per kg and 75 to 100 milligram per kg dose, roughly it comes to giving one double strength tablet to 8 kilogram per 8 kg of the patient. For example, if the patient is weighing suppose 40 kg, you may end up giving 5 tablets of cotrimoxazole in a day in divided doses of 2 to 1. So likewise, you treat these patients, and the duration of the treatment will be 3 weeks. And as far as treat ART initiation in these patients is concerned, you may delay a bit. So ART initiation can be done after 3 weeks in these patients. Corticosteroids may be um, can be given in some patients, especially if the PCP is severe, but in mild cases it may not be required. This is one of the example of before treatment and after 14 days of treatment with cotrimoxazole. If the patient is allergic to cotrimoxazole, you may end up using dapsone, or clindamycin is another choice of treatment. Some people, they advocate desensitization with smaller dose of sulfur drugs or cotrimoxazole, but usually it doesn't work, or it requires hospitalization and require those smaller doses of sulfur drugs, and usually we don't take those chances, so we may give clindamycin and primacoin in those patients. So this is how desensitization can be attempted, but obviously if the reaction is severe, so you should not be subjecting that patient to sulfur drug again. CPT is started if the CD4 is less than 350 or the clinical stage 3 or 4. And it should be continued for the patient for at least until the CD4 goes above 350 on at least 2 successive occasions of 6 months apart. That means all patients will be on CPT prophylaxis for minimum period of 1 year. I understand that there is a availability of CPT issue, but we are discussing about in ideal scenarios, if you have sufficient amount of stock, then this is how it is given. All patients of CD4 less than 350 or clinical stage 3 or 4 will be eligible for CPT prophylaxis. In children, all children exposed to HIV, that is born to HIV positive mother, as long as they are 5 years old, we continue giving them CPT unless until their HIV status is excluded. This is another case of lobar pneumonias. So for pneumonias, you may treat with outdoor approach or indoor approach. So before giving any tablets like ciprofloxacin or any fluoroquinolone for that matter, you should be sure that patient is not having TB. So that is why you may start with simple amoxicillin or co-amox clavulanic acid treatment. And if for hospitalized patient, you may require third generation cephalosporin or fourth generation cephalosporins also. And other factors also need to be considered, there can be mixed infection, like the patient may present with nova pneumonias, but there can be underlying TB as well. So sometimes if there is no proper improvement in clinical features or clinical signs and symptoms, then we may end up adding treatment of TB also in such patients. So this is just there are examples of pneumonias and how that is after response to therapy. So amoxicillin can be given, and also sometimes patients require hospitalization, especially in lobar pneumonias, they should be hospitalized. Then there are some atypical infections also which usually you don't see. For example, nocardiasis. This is some one very good example of this infection. For patients whom are on TB treatment and suppose they are not responding to TB treatment, there can be multiple reasons. One of the reason is nocardia. Other reasons can be failure to TB treatment, MDR TB, and list can go on. But nocardia is another example which may mimic tuberculosis, where AFB staining is done, but it is kind of cold staining. When you do AFB staining by smear examination, for smear examination, usually after putting carbolfuscin, you heat the slides. So here in quinone acid fast stain, you don't heat the slides, and that is how you can identify nocardia. So those labs which know what to look for, they can give this a diagnosis for you. And if at all you diagnose them, you can treat nocardia with cotrimoxazole and amikacin or imipenem or meropenem you can be given in such patients. So there can be other examples like histoplasma capsulatum, penicillium manefi, or other infections can be also seen. There are non-infectious causes which also may manifest as pulmonary manifestation, like lymphoid interstitial pneumonitis or LIP, commonly called as. So it is again an interstitial disease. If you give steroids, again patients get better. Again, ART initiation will be important. Lymphomas, Kaposi sarcoma, and lung cancer. These are the other non-infectious causes of of pulmonary involvement. So by and large, what we have seen in this presentations is like pulmonary manifestations and GI manifestations, and also the uh, um, other OIs. If you see, some of the OIs are preventable, though for them prophylaxis can be given. But as an ultimate option, I think ART initiation soon, if you can do in these patients, you can prevent them from acquiring other opportunistic infections. One quick note about the immune reconstitution syndrome. This is a long presentation, so I'll not be going in details of that, but just to put across the concept of iris, to define iris, again, that temporal relationship with ART initiation is important. It is called as iris, that is immune reconstitution inflammatory syndrome, because uh, after reconstitution of immunity after starting of ART, uh, it, the reinvigorated or reconstituted immune system can respond to the existing infection or hidden infections, and or causing ultimate deterioration of the patient's clinical condition or reappearance of signs and symptoms which were not there before. So that is how iris is defined, at worsening of signs and symptoms or appearance of new signs and symptoms after initiation of ART. So that after initiation of ART is important because that only can define as a sign or marker for immune reconstitution. And indirect markers are like CD4 is again a marker to define the reinvigorated immune system, and also relationship with viral load suppression itself is one of the criteria which can be used for diagnosing iris. Um, there can be different types of iris. I'm not going in etiology or the pathogenesis of iris, how it happens, but categories can be infection unmasking or paradoxical reaction. Obviously, unmasking means those hidden infections which were not seen at the time of ART initiation, but once you start ART, infections can come back. And paradoxical reaction is already diagnosed OI, and patients may be on those treatment of those OIs. And once you start ART, patients clinically deteriorate. And in those patients, there is a role of steroids. And at some point of time, you may consider even stopping ART in if the OI is life-threatening, for example, cryptomeningitis and those kinds of OIs. There can be other kind of categories of OIs like autoimmune malignancies and other inflammatory conditions. And what we can do is, again, what is the common OI which we come across is TB, because of the only fact that TB is the most common OI, and that is why we see TB as most common cause of iris also. So as far as treatment goes, as I mentioned, for infection unmasking, you may consider giving TB toxical reaction, just steroid will be enough. So this is just an example of iris PCP. Here you can see in the first X-ray bilateral shadows, and after initiation of ART there is worsening of shadows, and after therapeutic dose of cotrimoxazole, again you will see declining of those shadows. This is another example of iris histoplasmosis from Calcutta. So after giving itraconazole, it was reduced, but then when ART was started, again this clinical picture had come up, and after again starting of steroid therapy, this is what was seen after 7 days of prednisolone. So this is how it works. This is another example of leprosy, where another example of CMV retinitis. So any OI can, after ART initiation, can reappear or worsen as iris, which can be managed in these ways. So this is what I thought I should be discussing in today's clinical contact session. If there are any questions, I would be happy to answer. Otherwise, I think it is really important for you to complete those quizzes and homework assignments. Uh, and uh, and if there are many more questions, if you want to ask later, you can post them in WhatsApp group also.
There's one question in the chat box.
Okay.
Yeah, it is which size of mesenteric lymph nodes is considered for TB abdomen?
Uh, yeah. So if you want to say what is significant size, usually whenever lymph node is more than 1 centimeter size, usually it is considered as significant. But and also we, as I mentioned, we end up treating that patient as case of abdominal TB. But it is obviously not a specific diagnosis. If you want to confirm the diagnosis, then only option is to do CT guided biopsy of the lymph nodes. But if these are matted lymph node or multiple lymph node more than 1 centimeter size, then and with again low CD4, showing symptoms of TB like fever for long duration and all that, I think that is enough to treat that patient for tuberculosis. But size of lymph node more than 1 centimeter size, it is good enough. But as I said, that is not the like cutoff for confirmation of diagnosis, but just as a guiding criteria, you can take that and you can start treatment of TB. Yeah. Any other question? Okay, if there is no other question, I think we can stop here. Thank you very much, and stay safe. And please submit your assignment as soon as we can. And we are in the 8th week. It's just 3 weeks to go. So wish you all the best for the remaining course. Thank you.